Hello, everyone. What you're about to hear is an interview with Dr. Ryan Mynatt, who is a doctor of pharmacy at the University of Kentucky, and he specializes in infectious disease. I've reached out to some hospital friends and asked them who they would recommend me interviewing about the coronavirus, and they all recommended Dr. Mynatt. We had an excellent discussion about the coronavirus and viruses in general, and I believe that you will be pleased with the interview.
Bit more of my publications before were in my former job at Detroit Receiving Hospital. Just a little background: I'm an infectious diseases pharmacist, so a lot of public perception is pharmacists behind the counter putting pills in the bottle and then counseling the patients, being a very visible, accessible healthcare provider. But there's a large component of us that work in the hospital. We can focus on operational aspects, such as compounding for intravenous formulation, oral dosage forms, those types of things. And many of us specialize in certain areas. My area, for instance, is infectious diseases. Interestingly, got into it by reading The Hot Zone by Richard Preston when I was young. Uh, but found that I really liked that, rounding with the physicians and doing antimicrobial stewardship, which is really just optimizing the use of antibiotics in general. And did that in Detroit for about 10 years after I trained at the University of Kentucky, both for pharmacy school and as postgraduate training as a resident.
I'm already impressed. You're a doctor of pharmacy that specializes in infectious disease. Are you a professor as well at the UK College of Medicine or
Well, I'm
College of
relative.
Pharmacy?
Oh, yeah. No, relatively new. I will take students on rotation eventually. Um, the modality of how they conduct rotations now is in flux, but at the same time, I wouldn't say a professor in the sense that I have a tweed jacket or you know have office hours or anything like that. But I think eventually we'll try to train future pharmacists to do similar things when they come on rotation with me or my colleagues.
So are you practicing right now or are you mostly conducting research?
Practicing, I recently moved back from Detroit, and I'm building the University of Kentucky's outpatient antibiotics program. So basically, many patients can receive intravenous antibiotics not in the hospital or healthcare setting, and they can do it in the comfort of their home. So I try to transition those patients by simplifying their intravenous regimens to something that's a little bit more manageable at home. In the hospital, we have nursing staff 24/7, so they can administer those agents. But at home, it's either the patient or the patient's family. And oftentimes we can't do the same 7 to 8 infusions depending upon the regimen. So I try to simplify that down to maybe two or three.
So what particular area interests you the most in medicine?
Uh, I like pharmacokinetics and pharmacodynamics, which to simplify what those are, pharmacokinetics is basically how your body handles a drug. So how you give it, where it goes when it gets inside of the body, how long it stays there, and how you get rid of it. And then pharmacodynamics is how the drug affects the patient, or in this instance, in infectious diseases, how it affects the microorganism or virus. So I'm very interested in how we can optimize those. And oftentimes we have to know the pharmacokinetics of the drug inside and out to better kill the microorganism more efficiently while minimizing any toxicity to the patient.
And I think that that will be important later on when we start talking about management and medication management of patients with suspected COVID. And if people didn't know, that's our topic for today. Um, Excellent. Could you give us a breakdown of virology and in general? And is that an appropriate term for what we're going to be talking about? Virology.
Well, I think in general, probably so. I mean, obviously, we're talking about a coronavirus. We knew before that there were coronaviruses that affected many different types of animals, dogs, cats, cattle, those types of organisms. And then eventually, as we got better at diagnoses and molecular testing, found that they comprise many human pathogens. In fact, a lot of community-acquired pneumonias and respiratory tract infections can be traced back to virus infections versus bacterial, which is something that as an antibiotic steward is important to remember because antibiotics don't necessarily treat viruses. But I think it's an appropriate term when we discuss the life cycle. I mean, I think that was one of the things you had wanted to discuss. And I think it's important that to differentiate a bacterium from a virus, and that a virus really takes advantage of the host's machinery, so this our own cells, to replicate. And that's one of the reasons why sometimes the treatments can be toxic, because oftentimes the drug targets used to halt the replication of viral particles can mean that we have to target our own machinery to do so. So that's somewhat of an issue, and we can talk about that later. But in simplistic forms, you have a virus. It enters the cell, utilizes the machinery to replicate, and then ultimately, either by controlled release or lysis, makes more viral particles that can then go on and infect other cells within the body and then other people, as we'll talk about with transmissibility, because it can be spread from person to person by different mechanisms.
So going back to being a good steward of antibiotics, do you get frustrated at physicians that freely give out antibiotics to patients with viral symptoms?
Well, I think that I get how some people and providers get into that cycle. I think, especially in the United States, oftentimes patient satisfaction is a big driver of business, and I think that I get both sides of it. I wouldn't say that I get frustrated from that sense. I think that oftentimes you have to understand the perspective from the provider. But at the same time, I think it does spurn other problems down the road, whether it be toxicity from the drugs themselves, allergies, and or antimicrobial resistance, which can be a huge part of kind of my colleagues on the inpatient side seeing more resistant bacteria, which become harder and harder to treat over time.
So you talked a little bit about, I think, mutation of the virus. So I think COVID, it's rapidly mutating. But last I looked, there were two main types of SARS-CoV. Was it SARS-CoV-2? Are those the most prominent, the L type and S type? And what does that mean?
Yeah, those were described early on. The interesting thing, and this is kind of what I try to teach my residents and students, we oftentimes will never know which type the patients have. You just know that the patient has COVID-19 based upon how we test. But ultimately, you could have different strains. I believe one of the types is more aggressive in the sense of the disease manifestations than the other. But oftentimes, in the clinical realm, you're not going to know that the patient has an L type or an S type until long after, and you do more in-depth sequencing of their particular strain of the virus. Often what we're going to be able to know is that you send a test and it's positive for COVID-19, not which type it necessarily is per se.
So do you know if the differences in the types are related to clinical presentation or morbidity and mortality?
I think based upon my limited, because again, it was more described earlier on, less so in the more recent literature. I think that one was noted to be associated with more aggressive disease in terms of severity, but at the same time, I think my impression of the data would be that I think it's really, we've only had these reports going for the last 2 to 3 months. So in the realm of science speak, that's quite limited in terms of the amount of data, and oftentimes very abbreviated reports. So I wouldn't want to speculate and speak incorrectly about it. But yes, I mean, I do think that initially there were reports that one of the strains was potentially more aggressive than the other, and comprised, I think, a great amount of them, at least in Wuhan. I have not seen, admittedly, any report to that effect in Italy or the United States thus far, so I wouldn't be able to speak on that.
Right now, I myself am rarely on the front line dealing with this thing. I'm trying to provide support and proper education to our crew members who are on the front line. And it seems like, we do daily briefs and we're always updating the policy and changing our recommendations to the crew members. And I think we're learning more and more about how it's transmitted. Early on, I believe they thought it was mostly just droplets. They thought it was mostly transmitted via droplets. Well, we know it's probably transmitted via aerosols, maybe even eddies, and now they're thinking definitely fomite transmission. Is that accurate?
Yeah, a lot of what we are seeing in terms of protecting healthcare workers is really reducing the immediate risk when you're performing procedures and or making sure the work area is clean. I think, when we talk about aerosols versus airborne, the big, droplet would be, I think everybody's kind of familiar, or at least we shared in the last 2 to 3 months, a picture of the 1940s or 1950s where the gentleman sneezed and you can see all the droplet particles go. That's kind of my understanding where the whole 6 feet or 2 meter recommendation came from. Because the thought process would be that you shed the viral particles in the nasopharyngeal area and you sneeze or cough, and that really kind of is like a cannon for the bacterial or the viral particles to then be expelled at great distance from the person. Um, I think that they're learning a little bit more, and again, you've seen that more evolve over the last week to couple weeks, where it could be as much as even talking can generate enough viral particles to expel it and or breathe closely. So, we kind of don't think about that, but when you're sitting at your desk or you're sitting at somebody else's desk or you're kind of getting coffee at work, you're kind of potentially expelling those viral particles onto the immediate area around there. And then potentially, if they have longevity on that surface, which is kind of the fomite transmission theory, they can be transmissible for a significant length of time, which presents a huge infection control issue. And again, that's one of the reasons why limiting travel or exposure to other areas and then washing, obviously, your hands is a big component of infection control in this instance.
Yeah, initially we in our department we were just requiring surgical mask on every call. Now and then we just started requiring surgical mask in the ambulance because you can't social distance, and now we're requiring surgical mask at all times at the station unless you're like outside or asleep. um, and that's kind of
Yeah,
scary.
it is. I think there was a really nicely done image, kind of. I don't know if it was. I would say a thermal image, but a surgical mask really kind of helps protect. Like for instance, if I share an ambulance with you, and I'm infected, I'm breathing into the mask, and I'm not necessarily expelling those viral particles out far enough to potentially infect you or the person that we're transmitting or transporting. And you're seeing a lot more universal masking data and recommendations emerging. I think we're going to be going to that in the hospital soon for those persons going to work at University of Kentucky. So you'll be seeing that, and I know that there's many facilities, including my former facility in Detroit, that have also from the imagery that I'm seeing from my colleagues, donning universal masking as well, really to kind of limit spread, but also protect the person. Surgical masks, I think, it's important to remember, were developed to protect the patient from the surgeon, if you're talking during the case, but also provide some level of protection from blood and body fluid exposure to the surgeon and staff. But they don't do as much to potentially limit exposure to the virus as, say, an N95.
I think that's important to differentiate. We require N95 or some kind of respirator if we can get it on all aerosol producing procedures. But you mentioned viral shedding, and I use that term pretty regularly, but I'm not 100% sure I know exactly what it means, if we're being honest. So, what exactly does that mean?
So the example I would use is kind of like my dog. She's got little white fine hairs, and I think you can find them all over the couch or the floor or anything like that. So when we talk about viral shedding, it's similar in the sense that if I'm shedding, I'm kind of expelling viable virus throughout the day. And when we talk about shedding, especially in forms of treatment, we look at things in terms of halting viral replication, which again would also potentially limit viral shedding. Is oftentimes very heavily described in influenza literature, which is one of the benefits of treatment with those agents is that it can limit viral shedding timeframes, which in essence can limit infectivity from a singular patient or person. So shedding would just be kind of like shedding virus, like you're shedding hair.
That makes sense. Now, is viral shedding related to viral load?
It can. I mean, simplistically, not being a viral expert myself, I would say yes. I mean, the higher viral loads in a person's body may make them shed more, especially if they're coughing profusely or emitting viral particles quite frequently. Um, Versus having lower. That's actually one of the critiques of some of the data that's emerging when we talk about treatments is the modality via which they're testing. Is it nasopharyngeal? Is it pharyngeal? Is it throat swab? Or is it lower respiratory tract? Because the yields from those can differ depending upon the literature and time frame of when the patient's actually in their infectious window.
I've seen a lot of people performing nasopharyngeal swabs, and the technique is pretty awful. A lot of them try to stick it in the brain as opposed to actually more horizontal. And I saw that there was a recent thread on Twitter earlier. And do you know if that would affect the sensitivity of the test or not?
Yeah, that is one of the big critiques when you look at some of the data that's emerging is, can we say that the technique was standardized across the person's obtaining the test? Because again, if you're, a newer practitioner and you don't do the test appropriately, the ability for the test to accurately identify the presence of the disease is going to be limited. Um, and so, yeah, I do think that if we're not practicing good technique, it will impact our ability to appropriately diagnose uh, coronavirus or any virus for that matter. It's not even limited to viral data. It's also in bacterial data. When you look at pneumonia, it can be the appropriateness of technique is very much related to your ability to identify the pathogen.
So with pneumonia, would it be? Are you actually getting like a sputum sample or?
Yeah, there's a nice report out of JAMA that actually compares across nasopharyngeal, sputum, lower respiratory tract samples from ventilated patients, whether it be protected specimen brush or lavage fluid. So that yeah, there are differences in yields based upon, I guess, how you're obtaining it. But the similar to bacterial diagnosis too. Sometimes we don't trust sputum samples as much as we would a lower respiratory tract sample that was obtained in a bronchoscopy suite.
Interesting. I think that's amazing. I kind of liken it to, the number one cause of severe hyperkalemia is a traumatic IV puncture. So I just think we need to have some reservations with our processes of obtaining these sorts of things. In terms of viral load and viral shedding, I know PPE has differing levels of, I guess, filtration and effectiveness, but you have to be exposed to a certain viral load of the virus. Like you can't just get, I don't know, a single micron of the virus to become infected. Is that correct? You have to be exposed to a certain load.
Well, I do think, and I don't know the specific lower number there. that we would need. But yes, I mean, generally the concern would be a higher amount of exposure to virus would lead to a higher likelihood of infectivity of that person that's been exposed. I haven't seen anything that says, one viral particle or viron would be enough to do that. So I won't want to speak to that completely. But generally, yeah, I mean, the higher amount of virus that you're exposed to, the higher likelihood you potentially will transmit that virus. I think if you look at, for instance, HIV, which is transmitted in a different way, the viral load does play into the ability for one person to infect another person. For instance, low viral loads can make the likelihood of you becoming infected, whether it be via needle stick or blood body fluid exposure, to be remarkably low. So that I don't know the data with coronavirus that if any's been published as to an amount, but it makes sense to me.
And viron, that's the word I was looking for. That's a single virus, a viron, or a
Yes, I believe so. People are
okay.
allowed to critique later on. If we want to have commentary, they're more than welcome to critique me on that.
That's fine. I get plenty of critiques. I'll just update the show notes and say, hey, correction on this part. But that leads nicely, I think, into maybe the incubation period and talking about when are patients most likely to transmit the virus. And I think that, the CDC just updated their guidelines telling everyone that if you're going out in public, wear a face mask because, and I was reading the CDC's release of articles this morning about how you can be completely asymptomatic but still transmit a heavy viral load, heavier than they initially thought. And that's probably why they updated their recommendation.
Yeah, that's correct. I think when you look, I think there's a couple different examples that you and your listeners could look at. I think the first comparing and contrasting was with South Korea and Italy. I think when you look at testing differences between the two countries, uh, South Korea really tested everyone. And what they found was quite striking. I believe when you look at persons aged 20 to 30, they had a 20 to 30% positivity on their testing rate. However, when you look at people who are symptomatic, they may comprise a very small number of them. Now, comparing that to Italy, they were only testing very symptomatic people because of limitations in testing and just volume of sick patients. So they did not note that. And I think that that's also noted between Iceland and the Netherlands, where one tested everyone, whereas the other only tested the sick persons. And I think as this situation has evolved, what you've really seen is we have a large component of persons, particularly the young, that will be infectious but not know that they're infecting others, which presents a problem because, again, it's kind of like convincing someone that they have hypertension when they have no symptoms of hypertension, right? Take your medicine. This is going to be a problem long term, but there's no ill effects in the person at that exact time. It's very difficult to see that that's a problem. And I think that that's where we've had an issue for a long time. When I look at some social media posts by some of my colleagues in infectious diseases, they're noting they're sick older persons haven't been outside, but they've had visitors, younger people that aren't symptomatic, and they think and presume that that's potentially a vector of how this is spreading so efficiently. Is people who don't think they're infectious are infecting people who are at highest risk. And I think that they're trying to arrest that by saying, okay, well, if you are going to go outside, limit your ability to kind of expel infectious viral particles by wearing a mask, which really kind of keep that cloud, so to speak, around the person themselves versus like into the air around them.
And that's probably why expanded testing capabilities is so important.
Correct. That's one of the critiques on the limited testing we currently have is we don't have enough capacity to test everyone, so a lot of times we're testing only the symptomatic.
And it's kind of sad because I think we just purchased a limited number of our own tests to conduct internally, but it's like by the time you get the results back, the 14-day period has elapsed and that person is going to be returning to work anyway, or they're going to be in the hospital or possibly dead. So,
Yeah, correct. I think, and to your original question, from an infectivity standpoint, it really can vary by the patient. So, I mean, depending upon, I don't know that I specifically seen anything, but what I have seen is more in critically ill patients or higher severity of illness patients. Their ability to be at least PCR positive can be quite long. I think if one looks at, say, the data from the New England Journal for the lopinavir ritonavir data, I mean, those patients were positive on PCR tests out past 20 days, 28 days. So, I mean, that can be a huge infection control issue, but it's something that, again, similar to the influenza, we know can be prolonged, and especially in critically ill patients, because their immune system has sustained a huge hit, and they may not be able to fully clear the viral particles as a more healthy, stable person might be able to, especially an asymptomatic person.
and what does PCR stand for?
Oh, polymerase chain reaction. I apologize. It's basically a test that we commonly will perform. It doesn't. It may not necessarily tell you if a person's infectious, because an easy way to explain it is that we all have DNA and we can look for that DNA, and we use a polymerase chain reaction to amplify a retained genetic line of item of code that's unique to that virus or that bacteria. And we
Okay.
utilize it and amplify it to where we can detect it. So if you have a virus, remember it's very small and there may be a lot of virus around, but again, you can't see them, but you can take that PCR test, swab a patient, and then perform it, and then amplify that numerous times in a lab, and it can tell you whether that virus or bacteria is there or not.
And now most of the current tests, most of the ones that people are using only demonstrate whether or not they have had the virus, but they could possibly currently have it, but doesn't mean that they have an active ongoing infection. Is that
Well,
correct?
there's two different lines of thought. So there's we can potentially, they haven't done this on a wider scale yet. There are ways to test for exposure from a immune system standpoint, and they typically look for your immunoglobulin exposure. So immunoglobulins being our antibodies that fight off infections. So we have antibodies that react very fast, and those are typically the IgM antibodies. And then there's the ones that we, for instance, give people vaccines for. Those are called IgGs, and those typically take longer than a couple weeks to show up. So the thought would be that if you had an IgG to the coronavirus or COVID-19, you've been exposed to it, and whether or not you knew you were exposed, that is an argument for, can we test patients, because that goes into eventually, as you ask about therapies, like for convalescent plasma, so to speak, would that we be able to use those antibodies to help fight off the infection in a person who's battling it and critically ill?
Now, is that the same as testing? Is the IgG the same as testing for metabolites?
No, they're a little bit different. A metabolite would be more of a chemical structure. Immunoglobulin is a very large protein in your body, and we utilize them. We can make drugs that are actually antibodies. We make them in mice or sheep or things like that for different uh, indications. But humans make them as a result of exposure to certain pathogens and or viruses. And that's one of the reasons why every year we get a flu shot, because it'll allow us to formulate an immune response before we get exposed, versus waiting for it to happen after we've gotten exposed and had no ability to fight off. Now, to compare that to a PCR really just amplifies a piece of genetic material such that you can tell that the person has that there. So it doesn't tell you that it's a live virus and it's necessarily infectious, but that it's present, if that makes sense.
Okay. So I think maybe the utility of the PCR would be almost the same as the metabolite, or is that totally wrong?
Well, no, I mean, I don't. So a metabolite would be something that we would use in drug monitoring. The immunoglobulin would be something we talk about making convalescent plasma. But if I had an example for the PCR, so say if we did do widespread testing in the community, you'd be able to say, okay, well, you have 10 people and you test all 10 of them. Two of them are symptomatic and two of them are asymptomatic, and and you know, four total tested positive. You would be able to potentially tell the two asymptomatic people, hey, please don't go out in public, self quarantine for 14 days, so that they could limit exposure to other people. The other two that are and then subsequently monitor them for development of symptoms. I think if you look at the New England Journal of Medicine, they did a nice job at using the PCRs to detect positivity in nursing home patients in Washington. And then they were able to monitor those positive asymptomatic persons for development of symptoms later. And in fact, many of them did go on to develop symptoms of disease, but were perhaps caught early enough where they were infectious, just not symptomatic.
I think almost all of the staff eventually tested positive for it as well, didn't they?
There was a significant number. I can't recall that. There's just been too many papers that I've read to do that. But I do know that they did have a lot of staff, particularly older staff members, too, test positive and then also be symptomatic. But
Now,
that's the utility of catching it earlier versus having it rampant in the community where your capacity to test is not up to your number of persons that would require testing.
so is it even worth? Do you think it's even worth trying to determine the transmittability and of COVID-19? Since would it be accurate to even talk about that, or do we know?
Well, I think we kind of know. I think that it's changing in terms of the how we combat it. It kind of goes to your question that you posed early in your Word doc about the R naught. It does go into how we can look to control the virus itself, because again, if it's a highly infectious viral particle, we do need to limit contact between persons to persons. So I think, for instance, Governor Bashir, um, has done a nice job at really getting that message out there. He's become kind of like a little folk hero in some way from the social distancing standpoint, because again, the distancing part limits contact. And again, if you have a highly infectious particle that requires you to become in close contact with another person to transmit it to that person, limiting that is a component of it. So I think knowing that its transmissibility is a little bit more so than just a cough or a sneeze is important, because we're going to have to know that long term, because it may not go away soon. But I don't know that I would fully say that we should just forego studying it in that respect.
Well, maybe that's a poor choice of words.
No, I don't think
On
so.
my part.
It's a good question. I just don't. I think that we still need to know.
I get really frustrated with some friends, maybe even family members on my social media that liken this to H1N1 and say that our response is exaggerated compared to our response of things like H1N1. So, can you maybe elucidate a little bit on why that is and maybe how it relates to the reproduction number?
Yeah. So, having been a resident training in infectious diseases when H1N1 came out, I would tend to disagree with them. I think it was a big deal at that time. We had very sick people, particularly young people in the ICUs with H1N1. I think the issue is flu's been around. I think it always gets talked about. I think it's become the annual thing. And again, a lot of people do experience critical illness from the flu, particularly post-infectious pneumonia with bacteria, and get very sick. I think the issue with a coronavirus, COVID-19, is that we've never had this in the community. So, I mean, this is not only an infectious viral disease, you're also in a highly susceptible patient population that has never seen it. And so when you think about its infectivity and its ability to spread within a community, particularly affecting those with less uh, capacity to absorb a disease, or like the older person or things like that. I mean, it's different. It is going to overwhelm the healthcare system in certain areas. We're already seeing that in New York and places like Detroit, where I used to work, just from a volume standpoint. Because again, it's not that it could be. I mean, it's definitely higher mortality when you compare it to the annual flu and H1N1. Um, but the problem is that it's going to happen in a protracted time frame, and we've never been exposed to it, and it's going to particularly impact healthcare centers that have not an ability to prepare because of time. So I would disagree with them because we did not have that issue in 2009 because again, it was a new virus, but it did not cause the increased volume that this is going to have.
And I mean, also, our healthcare systems are almost built to operate at maximum capacity. Like, hospitals don't like a whole lot of empty beds to begin with, I think. Sure, we have surge capacity, but not to this extent. And I see a lot of memes showing the how many annual deaths there are from the flu. And I think they get mortality rate and like annual deaths confused a little bit.
Yeah, I think when you look at the annual flu and even the H1N1, the mortality rate was very low. It's going to remain to be seen what the overall mortality or case mortality is going to be. I think it oftentimes gets compared to the 1918 flu, which had a mortality rate of about 2.5%. Now, when you think about that, doesn't sound very high, but when you think about a few 100 million people in the world getting it at that time, that's a lot of people, right? It's just, I think
Yeah.
the estimates that the mortality impact was about 30 to 50 million people. That's because a few 100 million people contracted the disease. And that's the concern with this virus, is that, even if the mortality rate's 0.6%, which is kind of what South Korea saw, and they tested everybody, and then they looked at how many people died versus how many people got infected. It's still a lot of people, and oftentimes that's going to be multiple folds higher than even the annual flu. And I think that that's an important distinction that the people who are making the memes probably don't see, is that it's still multiple folds higher. But when you think about the sheer number of people that may become infected over time, I mean, that's a huge number of people.
Yeah. And do you think we could surpass the flu in
Uh,
terms of overall deaths?
are you talking about the 1918 flu?
No,
Oh,
I'm talking about like
um,
seasonal flu.
I mean, I don't want to speculate, but with the trajectory that we're seeing, it's possible for sure if we don't limit the spread. And again, I think the problem we're seeing, especially out of New York, is that these patients, including younger people, need a lot. Even if you look at hospitalization rates, even in the 30 to 40-year-old range, I mean, you might look at it and say, well, it's only 0.5%, or, that could be a completely inaccurate number. But if you talk about 100,000 people getting it, 0.5% of that number is still a lot. And it can add to your normal volume of the hospital, because patients are still going to get sick from other diseases that are common now. And so that's going to cause your capacity to have to absorb not only COVID patients, but also patients that are in traumas, that have flu, that have pneumonia, or, you know, other types of illnesses that require hospitalization. So that's the problem that we're going to see.
Yeah, people don't stop getting sick all of a sudden because there's an epidemic.
Correct.
Do you want to talk about some pathophysiology? And earlier, we have a Kentucky EMS professionals group on Facebook, and I told them I was speaking with infectious disease expert and asked them what kind of questions they would ask. And someone actually asked, since it kind of targets ACE2 receptors, would patients currently on ACE inhibitors see any benefit or any sort of protection, or maybe the opposite of?
Well, there's a lot of conjecture in that. It's a great question. So both SARS-CoV-1 and SARS-CoV-2 utilize the ACE2 receptor, which can be upregulated. So there's actually initially what we started seeing was, should patients that are on ACE inhibitors or ARBs or angiotensin receptor blockers stop taking them in hopes of downregulating the number of ACE2 receptors that are present. And the truth is, we don't know. The virus does utilize that as a cofactor for cell entry. So the argument is, well, these people who are at the highest risk of dying of the disease are we're making them more prone to infection. Well, there's also this pathophysiological mindset that potentially there's, in my understanding, based upon some of the reviews, some protective effects of those drugs too. I think it remains to be seen. And the problem is, if you have a person who's well controlled on an ACE or an ARB for blood pressure, for instance, and you start mucking with their antihypertensive medications, oftentimes those require multiple adjustments, which again may require an office visit, may require a trip to the pharmacy to get a new prescription, and that increases their exposure to people in public. And so that's one of the counter arguments for potentially just keeping them on what they're on and stable on, and then just limiting their exposure as from a social distancing perspective. So I don't know how that'll play out long term, but it was previously known with the SARS-CoV-1 virus particularly. And so I think it'll be teased out over the course of time. But at least for now, the majority of the experts are saying don't stop the ACE or the ARB.
So just mostly business as usual until we find out more.
Correct.
Now, so it targets the ACE2 receptors, and I think I researched and found that those are found in the epithelial cells, so like, smooth tissue type of cells. Now, what are they targeting? What do the ACE2 receptors do, and how is, COVID-19 affecting that?
Well, I don't think it. So to your point, I am becoming more knowledgeable about ACE2. I wouldn't say that I know all of the tissues throughout the body that it is expressed on. I do know that it's just more than in just the lung. I think the big issue that is at the heart of all of this is the ACE2. The ACE2 receptor is required for cell entry, and so if the virus, again, going back to kind of the whole viral replication process, needs that component to get in the cell, the thought process is if you have more of those receptors around, more viral particles will be able to infect the cells of the patient. So I think it remains to be seen, is that going to be a target for these in the future? I don't necessarily know. But I don't necessarily know how it impacts the day-to-day physiology of the lung. I think it plays a role in the normal physiologic oxygenation and workings of the lung tissue. So I don't know the ramifications of blocking it or targeting it per se.
Do you have any insight into the clinical progression, like the pathophysiology behind the clinical progression of the diseases, specifically like a cytokine storm?
So it's a great question. It's one that I don't think a lot of people know. Typically, what you'd see and what we're hearing is that patients will, they'll start with having a fever or a dry cough and then progress very rapidly to hypoxia and acute respiratory distress syndrome, or ARDS. I think that's one of the big things that and that they're trying to target is trying to minimize the transition of patients to mechanical ventilation, where the mortality is very high. So a lot of the therapies that are being discussed non-pharmacologically are, different modalities of oxygenation and diuresis to maintain adequate oxygenation in these patients. But typically, what you see, and especially the reports, is patients initially present. Now, not all patients will have it initially, but usually fever or dry cough, and then they progress from there to hypoxia, which is an ability to maintain adequate oxygen supply. And then eventually, a fraction of patients will need ICU level care to maintain their oxygen sets, whether it be through different modalities of breathing treatments or mechanical ventilation itself.
I think that's important to know. You mentioned diuresis, and as paramedics, we love giving fluid, and ERs love giving fluid. I mean, for the love of God, the Surviving Sepsis campaign says, hey, if they have SIRS criteria, give them 30 mLs per kg of volume. And this is not what you would want to do with these patients, clearly. And I think someone coined the term, and this has been going through social media, happy hypoxia. Like these patients are just like grossly hypoxic, low SpO2 sats, but they're fine playing on their phone, and they're doing like awake proning with them, just having them lay on their belly.
And again, I think to your point, that's what I'm seeing. So like I've been watching numerous podcasts and live streaming through like New England Journal, JAMA, and those types of, which have very wonderful sources of information on those particular subjects, because I don't presume myself to be an expert. But yeah, I mean, when you look at the progression to our ARDS, I think I've had it in a couple different ones described as the patients technically just drown, because when you think about it, it increases the amount of fluid, and that's particularly where people are saying limit, the volume expansion and fluids as much as you can potentially, and then practice good ventilatory practices, as you kind of mentioned from that standpoint, versus like giving tons of fluids from an early goal-directed therapy standpoint.
So I do know something that you were particularly wanting to talk about, and that is treatment. You mentioned plasma earlier, and I know that there is a lot of debate on hydroxychloroquine. And I know some physicians were using that for pre and post exposure prophylaxis. So what is the current evidence on both of those therapies?
Yeah, so there's a rabbit hole that we could probably spend the entire afternoon on. I think, to briefly summarize, I think there's a lot of data coming out, some of it have bypassing normal peer review. I think that one of the things that I've been doing is trying to temper fear with, a sense that we still need to maintain our wits and utilize appropriate literature evaluation from a patient safety perspective. I think that, when we turn to data that isn't, I say, robust in the sense that we didn't vigorously vet it before we employ it, we risk patient harm. And I think that we should always remember that we're here to first do no harm. I think, to your point, going back to the original SARS and MERS epidemics or outbreaks, there was screening of small molecules that had activity, and some quinine derivatives such as chloroquine and hydroxychloroquine were found to suppress viral replication of, for instance, SARS-CoV-1 and MERS-CoV-1. And so immediately when this SARS-CoV-2 outbreak or COVID-19 started to happen, a lot of people started looking at, is this a viable option for these patients? And I think, based upon the totality of data that I've seen, I think that at least what the discussion that I've had with my colleagues and what we know is that, at least in models, chloroquine and hydroxychloroquine do seem to inhibit viral replication at doses that we can give clinically. Because that's an important thing when you evaluate is like how much drug do you actually need to inhibit the viral replication? Because again, you're probably targeting some component of the patient themselves because the virus is using their intracellular machinery to replicate.
So maybe if we could give enough, then it might be beneficial, but like the dose
Correct.
that you might need to give could most definitely cause a long QT and subsequent arrhythmias or worse,
Well, I
Is
think
that
that
correct?
the thing is we know that at least the doses we give clinically we can potentially inhibit viral replication. I think the question is will this impact clinical outcomes? And I think that at least based upon the level of information that we have, I think the what I've seen and discussed, I think on a case by case basis, I think that we can have a discussion to say that at least the risk of treatment may not be outweighed by the benefit, or I guess the benefit will outweigh the risks. I guess
Okay.
the problem is when you think about from a manufacturing perspective for the number of people that will need treatment, the drug companies haven't budgeted for this. I mean, these drugs were marketed for malaria or, in the case of hydroxychloroquine, more autoimmune diseases. And the market for that is much smaller than, say, a pandemic. And so what this has caused is a run on the drug. And, from the standpoint of clinicians using it for post-exposure prophylaxis, I know of no data that demonstrates that is useful, and we just don't know that it will do that. But what we do know is that if there's a run on the drug, patients will not be able to get it for their rheumatoid arthritis or for their lupus. And what you're probably going to see are flares of these autoimmune diseases because patients will not be able to get these prescriptions filled. And I think at least in the coming weeks to months, I mean, it does beg the question: are we going to see more data come out? I think so. There was just a publication out of China, again, not peer reviewed, that showed the early use of hydroxychloroquine was associated with better outcomes. And I think we have to identify thought working groups that can evaluate these information and change the recommendations for therapy as better data emerges. But I think currently we just don't really have a lot. We have a lot of in vitro stuff that says the viral load goes down, but we don't really have a lot of great clinical data that says if I give this drug, patients who get it do better than patients who don't. And I don't know long term if we'll have that in the next week or two. We may have it in the next few months, but at least for now, I think we can have a discussion, at least around chloroquine, hydroxychloroquine, that they can potentially be employed, but it remains to be seen when they will have the most benefit.
I think we're all guarding our recommendations right now because we don't know.
Yeah.
So how is plasma working out, and how is that beneficial?
Well, it's great that you bring it up. They did have a report, which I still need to read. It's been hard to keep up with everything. They did it initially with the SARS-CoV-1 outbreak in the early 2000s. And they just published a report on 5 patients whereby they did that. I think that from a feasibility standpoint, there's a few things that have to fall into place. One, the FDA has allowed for the emergent IND, which is an investigation paperwork or approval process to utilize this. But basically, you take serum from a person who's had the disease and has recovered, and you take their antibodies and out of their blood, and then you use it in a sick person. And I think that that's probably going to be more and more employed as the pandemic ramps up, at least here in the United States. But you basically have to have a willing donor, a place to get the blood drawn, and then pheresed. A pheresis is where they kind of extract the useful serum from the whole blood product. And then you infuse it into the patient that's ill. obviously it's not a pharmacy thing. I just read about it because it's something that we're going to see clinically.
The CDC originally said, well, I don't even know if it was the CDC, but there were multiple reports saying Nsaids could make patients worse. And I thought I saw something saying that they pulled back on that. Do you know if that's true, or is there still a concern for patients on Nsaids?
I think that there's a couple things. One, there was conflicting information. I believe one of the leaders in France said don't use ibuprofen. That caused a lot of consternation. I think it's kind of based in science in the sense that similar to the ACE inhibitors, you can see it with ibuprofen an upregulation in ACE2 receptors in lungs. Again, I don't really know what that means. To my knowledge, I have not seen any data that suggests that patients should abstain from utilizing NSAIDs. Because actually, there's conflicting data because indomethacin, which is a nonsteroidal anti-inflammatory drug related to ibuprofen, actually may have in vitro activity. It remains to be clear to me how to translate that into humans. I'm not advocating it at all, but it's also similar to the whole ACE inhibitor argument in the sense that I just don't know what it all means. But it's created a lot of confusion in the process.
Yeah. So right now, ibuprofen, we just don't know.
That's my understanding based upon what I've seen and what I've been able to read.
And nothing taken from this interview is condoning one specific treatment over another.
No.
Excellent. Well, there were a few questions that some people have asked on Facebook, and if it's nothing that you know about, then you don't have to answer. Someone mentioned that a physician friend noticed a direct correlation between a lab value of 0 for eosinophil count and positive COVID test, and he and his fellows are working on a paper to be published. He's also said that patients presenting with GI symptoms are having worse outcomes. So I think that may have been two separate things. Do you know about the eosinophil count being 0?
I have not seen that. Obviously, if that's a finding and it is consistent with that, they should look to publish it if they desire. What I have seen, there are reports on the GI related issues. I think anecdotally, when I talk to colleagues in heavily hit areas, they are concerned about that too, because it may be one of the first signs that patients have. Which then again, if we have some GI upset independent of COVID, it makes us all kind of squeamish that we have it. But at the same time, like what I've typically seen more frequently are, the fever, the dry cough. I think that, what I've also seen is loss of taste and smell, been reported recently and discussed.
Yes.
But the GI issues could definitely be a part of the disease syndrome. Myself being not a diagnostician, I don't want to say it should be added in there. I think I would defer to my medical colleagues on that. But yeah, no, I have seen and heard about that in the literature. But the eosinophilia I have not seen.
But, again, I guess it makes sense since there's ACE2 receptors in the GI tract.
Correct. And that's one of the thoughts that why you might see that initially.
Is there anything that you just want to talk about or you think people should know?
No, well, I think that, I can talk all day on a myriad of things. I don't think that your listeners particularly want to listen to me drone on, but I think the biggest thing would be, keep an eye on the literature, be mindful of, speculative reports, especially being passed along. I think one of the benefits to social media is that we can find out information very fast. I think that it's oftentimes overwhelming, and then it can be a vector for the transmission of misinformation too. And I think that we should always be open-minded, read things, but then practice good evaluation of quality of information and the findings before we employ it. Because I think a lot of people are grasping at treatments because we have a lot of people who are sick, very sick in some instances, and we want to help. But at the same time, we don't need to do harm in what we're employing. And I think that that's where I kind of am on the outside looking in, because Kentucky's obviously waiting for their surge to start ramping up. But I do see it in other areas where they didn't have enough time to prepare. And we are seeing a lot of desperate treatments, heroic measures being done. I just don't know what it's all going to mean long term and what's going to be best standard of care based upon what we see later.
I think this is a really humbling experience, and we're going to be real humbled when we get on the other side of this thing.
Oh yeah, for sure.
It was great having you on, and I know that your time is precious, but I'm sure that everyone listening also appreciates that you took the time to come on. And if they have any questions, are you on Twitter? Would you want anyone to maybe follow you on Twitter or Facebook or any other platform?
Yeah, I am on Twitter. I think I don't really use a lot it for that, but they're more than welcome to try to. I think it's my name. Yeah, no, I have people follow me. It's if they want to see pictures of my dog, then. But yeah, I am on Twitter. I kind of don't utilize it as much for work related things, but if they have questions, they can most contact me that way.
Great, and if you all want, you can email me, and I will forward them to Dr. Mynatt. I'm sure he wouldn't mind that.
I wouldn't mind at all.
If we can't find the answer, we'll find it. There are more questions right now than answers.
I agree with that.
Maybe we can have you on the show another time. Hopefully not for another epidemic, but maybe to discuss something else that interests you.
Sure thing.
I hope that you all enjoyed this interview. And as always, if you have any questions for me or our guest speaker, please send us an email at curbtobed@gmail.com or find us on Twitter or Facebook. Our handle is @curbtobed. Thank you for listening. Bye.